Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. This week, it's Premier Education brought to you at no cost, thanks to our host, Medtronic, AstraZeneca, and Medela, the Science of Care. For our speakers this week, we have Dr. Arjun Nair, who is the co-chair of the next British Thoracic Society Nodule Screen and Incidental Detection Nodule Management Guidelines. And also we have Dr. Emily Bartlett, who's part of the guidelines committee, will be discussing the talk with us today. So without further ado, I will, because Dr. Nair could not be here with us in person, he's kindly sent a video, which we will run through for you now.
Hello everyone. Thank you so much to Professor Lim and the Virtual Grand Rounds team for the privilege of presenting to you this morning on incidental and screen-detected lung nodules, a wide-ranging topic. My name is Arjun Nair and I'm a consultant radiologist at University College London Hospital. These are my disclosures, probably most relevant of which to this topic is that I am the co-chair of the British Thoracic Society Pulmonary Nodule Guideline Development Group, but I must emphasize that the views expressed today are my own and not in any above capacity, particularly that of that development group. So I thought I would focus in on these particular areas given the diverse topic we're covering in this session. And I'd like to really ask ourselves two main questions. Are there differences between incidental, or what I'll henceforth be referring to as IPN, versus lung cancer screening detected, or LCS-PN, pulmonary nodules, now in terms of their prevalence, likelihood of lung cancer, so lung cancer prevalence, nodule and cancer characteristics, the stage breakdown and subtypes of lung cancer that we see in these populations, and the overall outcomes. And on the basis of this, answering that first question, is there then a justification for differences in how we predict malignancy within these populations? Can we use a catch-all one size fits all, or do we need bespoke models? And also, what implications does that have for management strategies? So on to the first of those topics. Are there any differences between incidental and screen-detected lung nodule populations with respect to nodule and lung cancer prevalence? The initial answer with regard to nodule prevalence is that we could expect a higher nodule prevalence in screening at a mean of about 33% versus 13% in incidental nodule populations. This is from the British Thoracic Society guideline, where pooled review was performed as part of the development of that guideline. In contrast, however, the apparent mean lung cancer prevalences between those two populations is quite similar, as you can see here, between 1.4 and 1.5%. But there is a relative dearth of data on these populations, in particular incidental populations, until the last decade. And as you can see in this table comparing multiple incidental pulmonary nodule studies, context is really everything, and this can lead to quite a heterogeneous reporting of widely varying prevalences for lung cancer. For instance, here, if you just look at the bottom line there, you're looking at prevalences of between 3.7 and right up to 78%. Now, in some cases, that's because that's a reflection of the smoking populations that are in there. And the prevalences in turn are therefore going to influence the positive predictive value of CT, as we know that the higher the prevalence, the higher the PPV. So we do have to take all of that into context. That said, interestingly enough, even when the smoking population prevalence in an incidental nodule population was about just under 46% of ever smokers, in this paper from about 2022 by Barchani et al. Showed that actually the lung cancer diagnosis could be as high as 10% in such a population. So really, incidental pulmonary nodule populations are not to be ignored. However, given that with regards to non-smokers especially, data on lung cancer prevalence and nodule prevalence comes primarily from Asian populations, we do need more data from Western countries if we are to try and understand the prenodule prevalences, how they change with age, and what that would mean for management strategies in Western countries with regards to non-smokers. And an example of this that has recently been published just over in the last few months is from the IMALIFE study, which is a Netherlands population-based imaging study that is a subset of the Lifeline study. And you can see here that when you divide it up into nodules, which are basically tiny, versus those that might be indeterminate, so-called clinically relevant ones, and finally the ones that we consider actionable, needing meaningful intervention now as opposed to surveillance, you can actually break those prevalences down into what you may actually recognize from screening populations as well. So you can, based on that, we can understand reference values, and these in turn can feed models and also the development of deep learning prediction models and detection models in the future. However, even when you look at this, these patients are at least 45 years old and over, so there is still a lack of data for those populations that are younger, and we are increasingly performing CT imaging on those younger populations. So the jury is still out on exactly what the prevalences look like for sub 45-year-old, sub 40-year-old populations in Western countries. A bit more data in Asian countries in that regard. Interestingly, this study by Gould et al. Performed in the last 10 years, which looked at longitudinal incidental pulmonary nodule detection over 6 years, 2006 to 2012, found that while there was increasing detection, this did not translate into an increase in lung cancer incidence. So lung cancer incidence remained relatively static, suggesting that there's all that's been is an increase in false positive detections. Conversely, though, the effect of granulomatous disease on false positive identification and screening, something that I would be worried about as a radiologist working in an area, for instance, with high tuberculosis or histoplasmosis rates, is debatable. And this study from the National Lung Screening Trial quite a few years ago now demonstrated that there was no real difference in the false positive detections by radiologists between what would commonly be referred to as the USA histoplasmosis belt versus those outside of that belt. So then, are there any differences in nodule characteristics, stages, and subtypes of lung cancer in these populations? Well, we know that IPNs that are lung cancer are also those that are more likely to be in the upper lobes, and there is a positive size correlation. So the same things we would see in lung cancer screening. However, I have to say, few studies record these characteristics consistently to enable an accurate conclusion to be made. With regard to subtype and stage, the Deluge prospective observational study, a multi-center study in the Mississippi Delta, offers some interesting insights. So they have compared 3 populations, and on the left there, a screening population undergoing low-dose CT, an incidental nodule population followed up in a nodule management program, and a multidisciplinary lung cancer presentation cohort as well. And what you can see there is that adenocarcinoma is slightly increased in representation in the screening cohort, a finding that's not always replicated in other studies. But also, interestingly, small cell cancer also found in a higher proportion in the screening cohort compared to the MDC, the multidisciplinary cancer cohort in particular, which is intuitively perhaps a bit counterintuitive, as small cell being central and nodal lots of the time can be quite difficult to identify on low-dose non-contrast CT. We also see a higher stage 1 distribution in both the incidental pulmonary nodule and screen-detected nodule populations compared to the multidisciplinary cohort, and that's not surprising, given that the multidisciplinary nodule cohort lung cancers that present will be those that present in later stages. Now, with respect to Asian and never smokers with incidental pulmonary nodules, there are 3 strong studies. The Talent study, which looked at never smokers at sort of a screening age, 55 to 75, with some risk factors, for instance, cooking exposure, especially lack of ventilation, that with 12,000 subjects found lung cancer detection rates of about 2.6%. Whereas the study in Korea from 2019, that was more towards opportunistic health screening in never and ever smokers, found lung cancer in only about 4.5% of never smokers, reassuringly the vast majority in stage 1. Most recently, the Female Asian Non-Smoker Screening Study, or FANS, presented its preliminary results in 2023, again in Asian never-smoking populations. It's a small study so far, 201 participants, but also found about 1.5% invasive lung cancers, all surgically resected. When we look at outcomes then of lung cancer from these two populations, are there any differences? Well, for stage 1 lung cancer, Gulati et al. Compared the characteristics and outcomes in incidental versus screen-detected populations. And what they obviously found was that the incidental populations were slightly older. They were also less likely to be current smokers, perhaps of a lack of awareness. And interestingly, also were more likely to have more comorbidities compared to the screening population. If you look at the overall survival, there was no difference in these two populations. What is perhaps a little interesting is when you drill down into it, for tumors that were less than 3 centimeters, once we go to stretch out the follow-up to over 100 months or so, you do see some separation of those curves with incidental pulmonary nodule detected lung cancers seeming to have a lower survival, though I don't think this seems to be statistically significant and perhaps reflects the older age group as well. Now, in a similar sort of three-way analysis from the Mississippi Delta cohort as well, comparing lung screening detected, incidental pulmonary nodule detected, and sort of neither pathway detected lung cancers, they found that there was not much separation in the survival curves. And interestingly, there was a similar prevalence of lipidic predominant, i.e. so-called slow-growing adenocarcinomas in all of these three cohorts. They also attempted to measure overdiagnosis crudely, in their own words, comparing the proportion of patients with lung cancer older than 80 years at the time of diagnosis who also had a Charlson Comorbidity score that was high, reasoning that obviously if these were people that had other adverse prognostic comorbidities, and we just happened to be finding lung cancer, that was a sort of measure of overdiagnosis. And there wasn't an excess in either the incidental pulmonary nodule or non-program cohorts, suggesting no overdiagnosis. Now, what about subsolid nodules? A personal area of interest for me. Should we be treating them differently between screening and incidental nodule detection populations? Well, we know that they're a risk factor for cancer in another location. The MILD trial from Italy showed us that, where there were no lung cancer deaths arising from subsolid nodules themselves, yet if you had a nodule, those subjects were almost 4 times more likely to die than those without such nodules. Now that seems counterintuitive at first, but the reason for that is because the subsolid nodule is heralding the future development of another lung cancer, perhaps more aggressive, not derived from that nodule but in another location. And this was a nice example from the MILD trial. Is this then also true for subsolid nodules in all populations not screening detected? Well, potentially yes, based on Schroeder et al.'s work from about 4 years ago, where they looked at the risk of lung cancer in another location when there was no abnormality in that region on a baseline CT, but there were subsolid nodules or solid nodules. And what they found was that the lung cancer-free survival probability markedly drops when at least 2 subsolid nodules are present, the reason being that these cancers develop in different locations. Again, reinforcing the fact that subsolid nodules are a biomarker of field change for multifocal adenocarcinoma spectrum lesions. How then do our existing risk prediction models fare on incidental versus lung cancer screening detected populations, given that many of these have been developed on screening detected populations. Well, previous evidence suggested that the Brock model performs well in incidental pulmonary nodule populations as well. Let's not forget that it was both developed and validated in screening cohorts. But in 2018, Chung et al. Demonstrated that when you extend that to patients 40 years and older with chest CT in quite large cohorts, you could still get relatively good sensitivity and specificity with an optimal cut point of between 6 and 8%, as opposed to the 10% that's employed in British Thoracic Society guidelines, for instance. However, the models are not very discriminatory for incidental pulmonary nodules that have a higher pretest probability of malignancy and that are referred for navigational bronchoscopy, as this study from Heidemann et al. Showed just last year. You can see that even with high smoking prevalences and large lesions, all of these models on display here didn't perform very well, especially when there was no PET-CT available. Now, hot off the press and only 2 days old by the time you're listening to this, a paper has just been published in Radiology Artificial Intelligence on the 5th of February, demonstrating that the models are overall suboptimal for incidental pulmonary nodules. Deep learning derived models may actually perform better for this incidental cohort, but overall existing models are poor for bronchoscopy, and in particular you can see here that the Brock doesn't do so well with an AUC of only about 0.49. And Sybil, which is a lung screening developed model, also seems to fall down when we get towards those nodules that would be referred for bronchoscopy. So I'll just finish off with some thoughts then on the need for different management recommendations based on all we've discussed over the last few minutes. We have different management recommendation or guidelines for screening detected nodules, such as lung RADS and the European Position Statement on Lung Cancer Screening, versus incidental pulmonary nodules guidance that's used worldwide for the most part from the Fleischner Society, and then the British Thoracic Society guideline from 2015, currently being updated, but which is, if you like, pathway agnostic, so it applies to all nodules, incidental and lung screening detected. Why would there be a need for different approaches for screening versus incidentally detected nodules based on all you've heard? Well, I think the potential for different age, ethnicity, and sex-dependent nodule and lung cancer prevalences, obviously the smoking prevalence, histologic makeup, and outcomes would argue that there should be a more personalized approach depending on the pathway. However, there is also a philosophical difference in that a higher threshold for intervention for those participants in screening is usually preserved compared to those who have incidentally detected nodules, the thinking being that the screening individual is asymptomatic, whereas the individual who presented for a thoracic CT for some reason or other had a clinical indication for that to be done. However, we know that the majority of patients with resectable incidental lung cancers are not eligible for lung cancer screening, and so it would be a missed opportunity if we did not try to harmonize approaches to incidental pulmonary nodules in the same way we would for screening. This has also been replicated in UK retrospective analyses, where Gracie et al. Showed that even if LDCT screening is implemented using all the sort of criteria we currently use, targeted risk-based criteria, strategies are still needed to ensure early detection of lung cancer in the majority of patients who may not qualify for screening. Even if they had a smoking history, they wouldn't meet the thresholds. So I think we need to harmonize and bolster our efforts in incidental pulmonary nodules, given that we put so much effort into screening detected nodules, and we need its own evidence base for management compared to what we currently do now, which is extrapolate in large part from screening studies. So things to finish off then, how do we ensure that? How do we ensure more prospective validation of nodule strategies for incidental pulmonary nodules? And how do we at the same time develop models that are more suited to IPNs in or non-smoking Western populations Can we incorporate environmental factors and genetic factors? And the last one is, as technologies change, such as robot-assisted bronchoscopy and surgical procedure options become available, will there be more convergence in nodule management? Will we change our thinking on how we should approach these, which will we become more aggressive or more conservative? Some food for thought there. Thank you so much again for the opportunity to present today on incidental and screen-detected lung nodules. I hope I've provided you with some interesting food for thought, and I'm very sorry I cannot join you for the subsequent moderator discussion.
Wow, thank you very much. That's a lot of information to be taking in there. Emily, your fellow colleague here at the Brompton, consultant radiologist, and also a member of the guidelines committee. Can I ask, what do you foresee are going to be the most important developments in nodule management going forward from here?
Yeah, thanks very much, Eric, for the invitation, and it's good to be here. We obviously have a problem at the moment in nodule management, which is that our guidelines are very heavily driven by the screening literature over the past 20 years. And as Arjun has helpfully pointed out, there are very many similarities between the incidental population and the screening population. But at the moment, we don't really have all the data that we need, particularly on the incidental population. And I think over the next few years, we are going to have to think very carefully about personalized nodule management protocols, particularly for people who we deem to be high risk. So, for example, for the Asian population who are at higher risk genetically of getting lung cancer, but also, these papers that Arjun has presented on the subsolid nodules and the risk of subsequent malignancy in people who have got subsolid nodules, that kind of data is going to become very important as we go forward. And it's a question of how we incorporate that kind of data and those biomarkers and that population into more nuanced risk models. So I think that's the direction we're likely to be going in. I'm not sure how quickly we're going to get there, but clearly it's a very complex subject.
Emily, thanks. I think I've agreed with everything you said, and I think that personalizing a lung cancer screening program is super important, not just for identifying individual persons at risk, but also every person seems to have a different threshold of when they want something done. Can I ask, how do you think going forward you would reconcile with really strange numbers? For example, in the NLST cohort, the high risk as defined by NLST criteria yielded a 1.2% incidence in lung cancer, whereas a talent study with never smokers had an incidence of about 2.6%. And the previous BTS guidelines, based on the Brock model, concluded that high risk was 10%. These numbers are very, very hugely disparate and doesn't allow for individual interpretation. Do you think the next set of guidelines might be an improvement upon this?
I don't know yet whether or not it's going to be an improvement. I think obviously those things are very, as you say, very difficult to reconcile. Brock is a little bit problematic for some reasons. For example, in the Brock model, as you increase the number of nodules that you have, your risk of malignancy actually decreases. So your Brock score goes down. But that model clearly doesn't account for people who have got multiple, for example, subsolid nodules, where we know that the risk of malignancy goes up. So that seems to be a model which is built on people who, for example, have got solid nodules, where as your risk of the number of solid nodules goes up, your risk of malignancy goes down. So, there are all these nuances with these models that we are not altogether transparent. And yet we use these every day in our clinical practice.
Thank you. I've got a question from Professor Paul Bass, who's asking, do we need different approaches for Western and Asian persons?
Probably, I think so. certainly the Asian population have got a higher risk of these subsolid nodules, particularly in non-smokers. And the data from the MILE trial, which Arjun was talking about, and the subsequent data from Schroeder is very, very interesting, because obviously this data has been collected on a non-Asian populations. One is a Dutch study and one is an Italian study, but nonetheless, both of them are saying that with multiplicity of subsolid nodules, your lung cancer risk increases. Now, what we need is an Asian study showing the same thing, which I'm sure will happen in the course of time. But unquestionably, there seems to be a bigger risk in the Asian population, which we're probably going to have to account for in our models. Now, the PLCO model, for example, does incorporate ethnicity, and I think that's probably significant in that model. But some of the other models that we're routinely using, for example, in the screening population, such as LLP, don't incorporate that.
Thank you. Also, the LLP has been developed in a relatively small cohort in the United Kingdom, right?
Mm-hmm.
For the other models, they have sub-characteristics of patients or to characterize non-smoking lung cancer within them as well, which I don't believe is well covered within the LLP Liverpool lung cancer model. I mean, that brings us very nicely to next week's talk with Professor Pancha Yang, who's joining us from Taiwan, who's a chief investigator of talent, who I guess will be going a little bit more into this. Can I ask you more of a question for Western countries? For most high-risk individuals who are Asian, lifelong non-smokers, they don't actually qualify for lung cancer screening. What provisions do you think are there or exist to actually help this group of patients?
Yeah, I think it's really difficult, isn't it? Because as Arjun said in one of those last slides that he presented, the majority of patients with lung cancer, in fact, won't be eligible for screening. And that is a concern. I suppose the flip side of that is that some people are eligible for screening. And of course, you have to start somewhere, and it's better to screen some people and pick up early lung cancer. It's very, very difficult in this in the population in the UK who are non-smokers to know how to detect these lung cancers early. Often they're asymptomatic and at an early stage. They present to the GP with a cough. A GP is not going to suspect a cancer in a 45-year-old with a cough. And so, the diagnoses in these people are very, very delayed. And, I don't know what the answer is, because we can't screen everybody. There's a cost to screening. It has to be cost effective. There's an associated radiation dose, which is another problem, something we think about in the Chinese population when we see young people with subsolid nodules. How often are we going to screen them, and that kind of question. And there isn't a straightforward answer to how we catch the lung cancers in the non-smoking population.
Thanks. There's a question from Pierre Modan, who's asking, multiple publications now, reporting on the impact of air pollution and the risk of lung cancer. Should we take pollution into account when deciding on when to screen, especially in non-smokers?
Possibly. I'm not overly familiar with the literature on air pollution, so I can't really comment. But obviously we need studies validating that there are many risk factors. Similarly, things like people who have got interstitial lung disease have a higher increased risk of lung cancer, and we don't account for that in our models. So there are many other things that we may need to incorporate into the models, but so far haven't been shown to be significant enough to make it into the previous models.
Yeah, I guess also air pollution is quite difficult because people travel back and forth and don't stay in the same place at any one time, and so the actual calculation of exposure becomes very difficult. I think one of the most high-profile proponents on air pollution has been Charlie Swanton, actually, on his models. So he's been giving a plenaries at ESMO last year, talking about the influence of air pollution on the development of lung adenocarcinoma. But I always point out that air pollution cannot be the cause of non-smoking lung cancer because it's 4 to 5 times more common in women. and of Asian descent. Now, if air pollution was the principal or an important cause, then the actual incidence of non-smoking lung cancer would be equal in both genders for the same exposure. So I have my doubts about air pollution as a identifiable etiological risk. Yes, it may cause in a small proportion, but certainly it's very far away from explaining the gender difference, which is about 4 to 5-fold. A very interesting question from Ralista Baranovsky is asking, what do you think the contribution of AI will be to develop more accurate models in the future? Do you think it's going to be a real big deal, or do you think all this is going to be a hype for the future?
I don't know yet. I think there are all these deep learning models that are now developing, and AI is definitely going to come into it. At the moment, I don't think we're quite there yet. I think alongside AI, there are biomarkers and other things which may be incorporated into models. I suspect that in 10 years' time, we will look back on this and think that we were very ignorant because we'll probably have these things, but only time will tell.
Yeah, I agree, because we're still looking at pictures as opposed to biological markers of cancer.
Exactly.
My last question to you would be, at the moment, if you were to place your bets, which do you think is going to be the most important biomarker that we will ally with radiology to give us improved detection for lung cancer?
Oh, I don't know. Some of the new blood tests seem to be very...
Circulating tumor DNA?
Yeah, exactly. Seem to be, might be the future, but time will tell.
Excellent. Thank you so much for joining us, Emily. Which only leaves us to thank our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. Next week, as mentioned, we have Professor Pancha Yang talking to us about non-smoking lung cancer and some updates from Taiwan, which all to say, thank you very much. Thanks once again, Emily, and have a good day, everybody. Bye-bye.
Bye.